So before I start, I'm going to just show you a few cases. I'll give you a few seconds to just think about what's going on. Case 1 is a 57-year-old man with nausea and jaundice. So here you've got a T1 weighted axial image through the liver, the venous phase of enhancement, and then the delayed phase. This is case 2, a 30-year-old woman with a liver finding found incidentally when she was being evaluated for abdominal pain with a CT, and then she went on to have an MRI for further characterization. You've probably seen these already, haven't you, in your... Case 3 is a 63-year-old man with abdominal pain. Case 4 is a 38-year-old woman with right lower quadrant pain. Again, this was an incidental finding on CT. She underwent MRI for further characterization. And then this is case 5, a 42-year-old woman who had a CT to investigate hematuria. So the topics I'm going to cover are obviously all the benign focal lesions that we have in the liver, the main malignant lesions that we encounter, and then a little bit about diffuse liver disease. So to start off, cysts, everyone knows what a cyst looks like, I hope. These are developmental in origin, and they are common, found in approximately 14% of individuals. They should be round or ovoid with sharp margins. The walls should be imperceptible, should not show any enhancement. On CT, there would be of fluid attenuation, and on MRI, should have fluid characteristics, low on T1 and very bright on T2, similar to the CSF. They can be single or multiple, and their signal intensity on MRI can be altered by the presence of hemorrhage, though hemorrhage is relatively uncommon in simple cysts, but does tend to occur if you have multiple cysts, particularly in the context of polycystic liver disease. Some pitfalls. There are other lesions that are very bright on T2, bright enough that they could be mistaken for cysts. And these include cystic primaries, cystic metastases from cystic primaries. And although often you should be able to differentiate a simple cyst from a cystic met based on whether or not they enhance, some do not show obvious enhancement. So that's just something to bear in mind. If you know your patient has a cystic primary, in the back of your mind, you see cystic lesions in the liver, and I'm not talking about the TSTCs, the less than 1 centimeter lesions. If they look like cysts, just be a little bit suspicious that it could be a cystic met, and what you just do is on the follow-up imaging, and for most malignancies, you have follow-up at about 6 months. A few of them, the tumors that are very fast-growing, such as hepatocellular carcinoma, you will do rapid follow-up at about 3 months, but for the majority of cancers, it's 6 months, and you'd look for progression. So here's one such case of a lesion that looked kind of like a cyst in 2002, and this patient had carcinoid tumor, and this lesion expanded cysts may grow slowly over time, but you wouldn't expect this kind of progression. This was a cystic metastasis. So metastatic neuroendocrine tumor is something to consider. Usually in this situation with very vascular tumors, as they grow, they can outstrip their blood supply and undergo necrotic change and cystic change, and you often see the enhancement around. But remember, there can be instances where they look very much like cysts. Or if you go back to this lesion, if you look very, very careful at the periphery, you might get a hint. There's a little bit of enhancement around there. Hemangiomas, if you only relied on the signal characteristics without contrast, particularly on MRI, hemangiomas can be confused for cysts. Since they're both benign, this is not really much of a concern, but you might just look silly making the diagnosis. Biliary cyst adenoma, remember you can get if you see a very, very large cyst in the liver, particularly if it's solitary, you should think of a biliary cyst adenoma or a biliary cyst adenocarcinoma. Based on imaging characteristics alone, you won't necessarily be able to differentiate. If you see any nodularity in the wall of that huge cyst within the liver, then you're obviously going to lean towards malignancy. Okay, so here is the classical appearance of a hemangioma. They're very common, more frequent in women than in men, and they are more common in the right lobe than the left lobe. And what they consist of is interconnected vascular channels, therefore they have slow flowing blood, and they will show attenuation on CT and enhancement characteristics that follow the blood pool. So here you have this typical lesion clefted, you have this interrupted peripheral nodular enhancement. Interrupted is key. Interrupted peripheral nodular enhancement that will eventually fill in towards the center. And this has a high specificity, pretty high sensitivity. It's not 100% because if you get very small lesions or very large lesions, they can enhance a little differently. So for a large lesion, if it's got central scarring, it can fill in very, very slowly. It may take up to 10, 20 minutes, even up to an hour, or may not even fill in completely because of the central scar. But it should show the same pattern, interrupted peripheral nodular enhancement. This is a T1 weighted image showing you again that clefted appearance, lobulated clefted appearance, clean, crisp walls, thin walls of a hemangioma, showing you the characteristic enhancement pattern and fill-in. Another reason why MRI is very helpful for hemangiomas, if there's any doubt on CT, because you're not sure of the enhancement characteristics, is that the T2 signal of hemangioma is almost as bright as a cyst. You can see in this example. Now, this is a large hemangioma, and it has a central scar, giving you a linear low T2 signal. But see how bright it is. This is not going to be a MAD. Having said that, the very sharp, the neuroendocrine tumors, very vascular tumors can also be very bright, but usually you can differentiate one from the other when you use a combination of signal characteristics and enhancement pattern. So here's an example of that large hemangioma where it's showing you this enhancement in the periphery. It's interrupted, it's nodular, but it looks a little weird because the lesion is so big and it doesn't fill in completely. And that, by the way, this is a delayed phase image. You see how the gadolinium looks dark in the renal collecting system? It's because it's delayed. Now, when you have very, very small hemangiomas, usually around about a centimeter or less, you may not perceive the peripheral nodular enhancement. They're so small that on the arterial phase, they'll just look like this flash enhancement. You'll get a small hypervascular lesion on the arterial phase. But the difference between that and a shunt or a MET is that when you look at the venous phase, or if you do a 5-minute delayed, the hemangioma will hang on to its contrast. So it will continue to enhance. All the other things will wash out. And so that's helpful when you have small lesions. And of course, if you're doing an MRI and you look at the T2, despite its very, very small size, 1 centimeter or less, it will still look really bright. And as most of you know, if this was a solid metastasis, and it was this size, and you looked at it on T2, it would be quite difficult to see. But this is so bright that you easily pick it up. So those are all clues for small hypervascular lesions that are hemangiomas. So what about some pitfalls? Now, we talk about interrupted peripheral nodular enhancement. Are there any other things that can enhance like this? And, how life is, of course, the answer is yes. So there are examples of treated metastases. Now, this is uncommon. So if they show you a treated MET mimicking a hemangioma, you're probably doing quite well. Treated metastases can do that. I've seen examples of colon cancer METs, gestational trophoblastic disease. They can do that, but you would look at serial images. If you have doubt, you say, well, you could do an MRI, you look for any prior images to look for stability. Or you could also do a red cell scan if the lesion is big enough. Hemangioendothelioma is a rare tumor. This is seen predominantly in the pediatric population or young adults, and this is a slow-growing tumor that can have the enhancement characteristics of a hemangioma, but as the disease slowly progresses, you get these multiple confluent lesions that coalesce in the liver periphery, and they're associated with capsular retraction of the liver. It's rare. Angiosarcoma, another very rare tumor that can have a similar enhancement pattern to a hemangioma in that it can be in the periphery and that it can be nodular, but generally speaking, it's a much more heterogeneous and ugly-looking lesion. So here's an example of treated gestational trophoblastic disease. Now you can see you've got nodular enhancement. It's probably not quite interrupted. And again, you'd wonder if the patient has any history of a primary, whether this was an incidental finding. Hemangiomas are typically incidental. This is an example of a hemangioendothelioma. I don't have one where it shows you the enhancement pattern here, but this is to show you how the tumor can coalesce, and it tends to occur in the liver periphery. And this is an angiosarcoma. You see it has this lacy appearance, it's peripheral enhancement. It is somewhat nodular, but even the areas of enhancement, they're not solid, they're heterogeneous. So it's a very more worrisome appearance. Okay, focal fat. Focal fat, this can be very easy to recognize if it takes its classical appearance and has its classical location in the vicinity of the falciform ligament, around the gallbladder fossa, or in the periportal region. If it's triangular or geographic in configuration, it's in those locations that I've just mentioned. It's low attenuation on the venous phase, you're done. You don't worry. You're not going to worry about this. They're going to say rule out tumor, follow it up. It's triangular, it's in the falciform ligament. So these features are all very reassuring. If there is any concern because, say, the lesion isn't triangular, it's sort of more round or lobular, and you want to really characterize it further, then the best way to do it is MRI. And of course, when you do in and out of phase imaging, on the outer phase imaging, the lesion, because it contains microscopic fat, will lose signal. So that's easy. Another useful feature to remember about areas of focal fat, particularly, if they are globular and there is some doubt, is to see if they have any mass effect. Fat should not have mass effect. So vessels should course through normally, should not displace structures. So that's another useful clue. Here's an example of quite a large area of focal fat. Now in the right lobe of the liver here, you've got this T2-weighted sequence. You can see that there's areas of high signal intensity, sort of a little bit ill-defined, not your classic focal fat appearance. And you do an in phase and an out phase, and all that area just drops out in signal. And notice, despite the size of this lesion, it's not really causing any mass effect. It's not really displacing the vessels in the porta. It's not sort of protruding out of the liver. Vessels are coursing through normally. So nodular focal fatty infiltration can mimic metastases, and MRI is very useful for confirming the diagnosis. Another feature that's been described of these lesions on CT in the past is a central area of high density. So on CT, if you see a low attenuation lesion that's rounded, no mass effect, vessels pass through normally, and it looks like in the middle it's a little brighter than around the edge, then again that's another clue. And here's an example of these so-called pseudometastases. You have these low attenuation lesions in the liver. If you look carefully, although this is a low attenuation lesion, you see centrally it's a little denser than it is in the periphery. And here, this was underwent an MRI to further characterize, which is a very reasonable thing to suggest. And you can see these lesions all completely dropped out in signal consistent with focal fat. Now, we talked about focal fat. You can also get focal fatty sparing. So this is an ultrasound from a 13-year-old boy with known familial polyposis coli who had gastric polyps, and he underwent a staging ultrasound. When he had this ultrasound, you can see there are these hypoechoic lesions in the liver that were concerning given its history for possible Mets. And so to characterize these, he had an MRI. So this is the appearance on T2. The most important thing to say about this lesion is that on the T2 image, it's dark. You breathe a sigh of relief. It's dark. It's unlikely to be anything unpleasant. Okay, T2 fat sat. It's disappeared. T1, don't see it. And on the T1 out of phase, it appears bright. That's a little bit confusing, and you can scratch your head about it, over this. But if you look at the background liver, what do you see? The background liver has dropped out its signal. So this is nodular focal fatty sparing. So when you're looking at what's happening to the signal intensity of your lesion, don't just look at the lesion, look at the background liver. What is the background? Because in MRI, it's all relative. Other benign lesions, focal nodular hyperplasia. The etiology of this is not completely clear, but it's thought to represent elements of liver hyperplasia which arise as a consequence of some congenital AVM. They are not that common, about 3% of the population, and they are usually found incidentally when a patient is undergoing a scan for something else. They are most prevalent in women. They are usually solitary, but they can be multiple. Typically, they're solitary. They are well-defined, they are often lobulated, and they tend to occur in the liver periphery, so in the subcapsular location. On MRI, they have a very classic appearance. But on CT, you'd expect these lesions to be hypervascular. They're hypervascular tumors. They have a lot of arterial blood flow, so they'll enhance brightly and in a homogeneous manner on arterial phase imaging. If you do MRI on them, quite often they're just slightly bright on T1 and slightly dark on T1 and slightly bright on T2. If you think about this, what you are dealing with is hypertrophied liver elements. So it's not surprising that it has similar signal characteristics to liver, but it might be a little bit too bright or a little bit too dark on T1. And the central scar, obviously, if you see that, it's very reassuring. When you see this lesion as an incidental finding, you're kind of done. So a central scar, which you don't always see that. You may see it in 50 to 75% of the patients. You won't always see it, that's when the questions arise as to, what is this? Now this scar, although we call it a scar, actually consists of bile ductules and vascular channels. So on T2 images, it will appear bright. So here's the enhancement. So on arterial phase, unlike adenomas, FNH should enhance homogeneously. Apart from the central scar, you may have a central scar and that scar can be hard to see. Should not enhance on the arterial phase, if you can see it. But on the delayed phase, what happens is that the rest of the lesion starts to wash out. How much it washes out can be variable, but that scar should stand out. That enhances on the delays. Here's another example of an FNH. T1, similar signal to the background liver. T2, similar signal to the background liver. Arterial phase, it enhances. And on the delayed phase, the lesion, again, similar signal to the liver, but you can make out this sort of a Y-shaped scar in the middle. Now, if you don't see the scar and you're uncertain about the diagnosis and it's an incidental finding, and like adenomas, FNHs occur in women, more commonly in women in a similar age group, you can perform a sulfur colloid scan because these lesions frequently contain Kupffer cells. They're normal liver elements. If it's positive, then you're happy. But often it's not. So this is a sensitivity of the order of 55%. So what can you do then? Well, you can biopsy it if there's real concern, or you can just follow it up. Now, why do you need to differentiate between FNH and adenoma? Well, adenomas can bleed and adenomas can undergo malignant change. FNHs you don't worry about. So that's why you do want to know. So if you have all the characteristics, or you show it's positive on a sulfur colloid scan, even if you can't see the scar, you're happy. If not, you might consider a biopsy. I also want to let you know, this is something you may or may not be asked about, but there's an increasing interest in the use of bimodal contrast agents, with some success over here, and there are other agents that are more commonly used in Europe, which will be used more here. You don't need to know too much about them, except for the phase. If you're using a bimodal gadolinium type agent, as well as giving you the blood pool phase of enhancement that you'd expect with gadolinium, it has a hepatocyte phase of enhancement. So if you have that, that will be taken up by the hepatocytes in an FNH, and this is starting to be used to characterize specifically, to differentiate between FNHs and adenoma. But I'll doubt you'll be asked about that, but just a little tip. So there is another potential tool coming up down the pipe. So adenoma we talked about as the most common differential. Other things that have a scar include large hemangiomas, but generally speaking, these lesions occur in a much older age group. Patients who are in their 50s and 60s tend to have the large hemangiomas, and it has a characteristic enhancement pattern. Fibrolamellar hepatocellular carcinomas also have a scar, which can also appear bright also have a scar, but that scar appears dark on T2-weighted images. Now again, the fibrolamellar HCC, it doesn't have to have any underlying liver disease. It could just be picked up as a solitary tumor, but it tends to be in a much younger population, young adults, adolescents, and they tend to be ugly-looking tumors with heterogeneous enhancement, whereas an FNH should have a nice homogeneous enhancement. Okay, so that's helpful. Now that we've gone over what the classic appearance of an FNH is, the fact that it's arterial homogeneous enhancement, the fact that it's well circumscribed, more common in women, there should not be underlying liver disease. That's really important. When you make a diagnosis of an FNH, you should not do it in the context of underlying liver disease such as cirrhosis or HBV. These should be an incidental finding. Here you have a patient who has HBV and cirrhosis. Now let's look at this lesion. Slightly hypervascular, where we see here on the delay, the lesion washes out. There's that central scar that's enhancing. Look at the T2, slightly bright. It's got a bright scar. Looks like an FNH, doesn't it? Has all the characteristics of an FNH. But the patient has cirrhosis. And so because of that, there was some concern. The patient actually had a PET scan, and it's really hot. And then this was biopsied, and it was confirmed to be a moderately differentiated hepatocellular carcinoma. So this is the one situation, even if it looks like an FNH, but your patient has cirrhosis or is high risk for HCC, I would still call it HCC. Here's another example. Arterial phase enhancement, washes out central scar, classic for FNH. Classic for FNH on T2, bright scar, but the patient has cirrhosis. And again, this was biopsied and it was found to be moderately differentiated HCC. Okay, adenomas. Adenomas tend to occur in the same age group, as I said, young women. It's associated with the oral contraceptive pill, but it can also be seen in men who are on steroids. It has a variable appearance on T1 and T2 weighted images because they can contain fat and they can have a tendency to undergo hemorrhage. So they can look quite variable on T1 and T2. They are hypervascular lesions, but because they can hemorrhage and they can contain fat, they are characteristically heterogeneous in their enhancement. Characteristically, that doesn't mean always. So here we have the example of an adenoma, T2 fat suppressed. Image, you can see here, there is a focal lesion, sort of mixed signal intensity on T1, slightly low in phase. Out of phase, it drops out a signal because it contains all this microscopic fat, and it's hypervascular, incidental finding, young woman, no underlying liver disease. Okay? So you're worried about adenoma. You're not going to call that an FNH because of all the fat that's present more than anything else. Okay, malignant lesions, metastases. Metastases is obviously very common. The hematogenous spread of a tumor, the liver is a very common site for this. Now, when we look at metastases, CT is the primary screening modality. MRI really is used as a second-line modality to further characterize lesions. When we talk about metastases, we talk about hypervascular and hypovascular Mets, right? The majority of Mets are hypovascular. Now, what does that actually mean? All tumors in the liver have an arterial blood supply. The normal liver parenchyma has a dual supply, portal venous and arterial. We know that, right? So when one goes down, the other goes up, and that's how the liver is so good at doing what it does. But for tumors in the liver, they have an arterial blood supply. Now, what determines whether they are hypovascular and therefore best appreciated on the portal venous phase, or whether they are hypervascular and they're seen on the arterial phase, is how much arterial blood supply they have. So if you have your common tumors like colon and lung and pancreas, what happens is that it has an arterial blood supply, and if you actually look carefully at the arterial phase of enhancement, you will see a complete intact peripheral ring of enhancement. You might catch it, you might not. But when you look at the venous phase, when the portal venous blood comes in and it enhances all normal parenchyma, that tumor is not going to light up because it doesn't have normal liver parenchyma, so it'll look dark on CT. Hypervascular tumors have a lot of arterial blood supply, so on the arterial phase, they're going to light up and be brighter than the background liver. Then on the venous phase, they don't have that portal venous supply, so they will wash out as the arterial phase washes out. On MRI, obviously, tumors are bright on T2. They're not going to be bright as cysts or hemangiomas. There are solid lesions. So this is a typical appearance of a liver metastases. Characteristically, they are dark on T1 unless there is evidence of blood products or melanin. So here's a classic example, MRI, T1 gadolinium enhanced image showing you an infiltrating tumor in the pancreatic tail, and then there's a metastatic lesion in the liver. There are certain that's the classic appearance of metastases. Now, sometimes they can have slightly unusual appearances, such as the cystic change that we describe. This is uncommon, but it can happen, and it should be considered in very hypervascular tumors, such as neuroendocrine tumors that can outstrip their blood supply and undergo necrosis and cystic change. It can occur in the context of cystic primaries, such as a mucinous adenocarcinoma of the colon, sometimes of the pancreas, and also of the ovary. So colon and ovary are the two most common primaries that can have Mets that look like cysts. But look carefully, you see even in the periphery, if you catch it in the arterial phase, you should see a complete ring of enhancement. Another characteristic, unusual feature that can happen with some Mets is calcification. Obviously, you're going to pick this up better on CT than on MRI, which is, how you usually look at these things. And if you see calcifications, you should think of two primaries. Serous ovarian, not mucinous. It's kind of opposite to what you would expect in the colon. And mucin-producing colorectal are the two that shows calcification. Hypervascular metastases, well, there's a certain group that you just should, a little list that you should have in your head. These include the neuroendocrine tumors. So, in other words, islet cells, carcinoids, pheos, thyroid cancer, sarcomas are obviously hypervascular, renal cell, classic hypervascular tumor. Breast is one of those that can be either hypo or hypo, but you should have a little short list in your head of all the common hypervascular tumors. And obviously for these, really you need the arterial phase to actually detect and appreciate the extent of disease. So let's move on to hepatocellular carcinoma. This is the most common liver primary. It's more common in men than in women. It occurs in the context of underlying liver disease, such as cirrhosis, or it can occur without cirrhosis in the context of hepatitis B virus infection, chronic infection. There are many other causes which include glycogen storage disease, hemochromatosis, anything that congestive liver failure that's resulted in cirrhosis, anything that can cause cirrhosis can potentially cause HCC. So these tumors, whenever you see a hypervascular lesion or a focal mass, a clear focal mass, or a bright T2 lesion in a patient who is high risk, first, second, and third, you think of HCC. And the majority of these will be bright on T2. Characteristically, the T2 signal is heterogeneous. It can be all over. Majority are bright, but they're not always so, depending on how well differentiated the tumor is. T1 signal can be variable as well because they can contain fat, they can cause high signal, they can contain copper that causes high signal, they contain iron that can cause areas of low signal. So in phase, out of phase helps to pick out fat. So the T1 and T2 signal intensities can be very variable, but the majority are bright on T2. Now, another important feature is, of course, they're hypervascular, so they will show arterial phase enhancement, and characteristically, this is heterogeneous. So anything that's hypervascular, particularly if it's bigger than 2 centimeters. Why is 2 centimeters important? Because, according to UNIS criteria, we can only really call it a hepatoma once it hits 2 centimeters. We know that our accuracy for diagnosing HCC when they are less than 2 centimeters is of the order of 50%. What does that mean? It means you can just flip a coin. So they need to be 2 centimeters. So a focal lesion in the liver, at least 2 centimeters in size or approximating 2 centimeters in size, you're going to think of hepatoma. Any lesion that's bright and focal, you're going to call, bright on T2 and focal, you're going to call hepatoma. Any lesions that's hypervascular and approximating 2 centimeters, you're going to call hepatoma. If it falls under the 2 centimeters and it's not bright on T2, but you think it's focal, but it's small, it could be a hepatoma, it could be a dysplastic nodule, it could be a shunt. What do? You follow it up in 3 months, 2 to 3 months, and you look for growth. If it grows, it's a hepatoma. If it doesn't grow, you continue surveillance, continue follow-up, another 3 months. If it's real small, if it's less than a centimeter, you say, okay, maybe we'll wait 6 months. The key thing is you don't want to let it get out of the box and hit 3 centimeters without you doing anything. Here's another classic appearance of hepatocellular carcinoma, hypervascular lesion. These tumors, they often wash out on the venous phase, so that's another very helpful sign. Even if you don't see obvious hypervascularity, or even if it's not really, really bright on the arterial phase, if on the venous phase it's showing obvious washout, especially if you see the ring of enhancement in the periphery, again, that indicates hepatocellular carcinoma. There are these tumors that some hepatomas can be very infiltrating. They won't be bright on T2, they won't be hypervascular, but if you look at this liver, you just get a sense that sitting in that right lobe, the right anterior segments and the medial segments of the left lobe, there's a focal mass. So this is an infiltrating tumor. And if you look at the rest of the liver, look at the rest of the liver texture, it doesn't have that same appearance. It's kind of just clustered in one area, and that's another appearance of HCC. Now, I doubt they'll show you stuff like that. If they're going to show you hepatoma, it will be the characteristic type, because this would be a little unfair. Now, the lymph nodes associated with hepatocellular carcinoma, it's an important point to bring up. Often these patients have underlying liver disease. Often these patients have viral hepatitis, particularly in this country. And so they may have reactive nodes, which can be quite big. They can be up to about 2 centimeters in size. So that doesn't necessarily mean that they have got tumor outside of the liver. But if you see a lot of nodes, and a lot of them are very big, particularly if they've lost their normal ovoid shape, they look rounded, they show abnormal enhancement. You think of tumor. Now, in this patient, didn't have an obvious tumor in his liver, but he had a lot of big nodes that was, a lot more than we would expect to see. It wasn't like just one node that was 2 centimeters. It was a lot of nodes. And so before biopsying, we generally don't like to biopsy hepatoma. Most places don't like to biopsy hepatoma because we're dealing with high-risk patients and because of the risk of seeding. So the first step was to do a PET CT to see, are these reactive nodes or do they look malignant? And they were really hot. So then we went on to biopsy, and actually this patient happened to have lymphoma in his nodes. But that's just to show that, look at the nodes, they can be big, they can be increased in number, but if they are really large or changed in shape or enhancement, then think of possible tumor. But it's uncommon to get nodal involvement. Venous invasion actually is very common with hepatoma. It likes to invade the vessels. The way you differentiate between bland tumor and tumor thrombus can be hard, but on a CT and MRI, you'd look for expansion of the vessel. Bland tumor doesn't tend to do that. Tumor thrombus does. And look for arterial phase enhancement of the tumor. And I don't mean in the wall of the portal vein. Remember, the portal vein has vasa vasorum, so the wall of the portal vein will enhance. I mean that within the meat of the thrombus, if you see arterial phase enhancement, you worry about tumor thrombus too. And actually, if you're not sure, Doppler ultrasound is a very, very good way of looking for that in the portal vein. So here's an example of this large tumor thrombus invading the portal vein. You can't rely on the T1, T2 characteristics on MRI. Okay, how good are we picking up hepatoma? Whether we use MRI with various contrast agents or CT, overall, we are not that great at making a correct diagnosis, 70-80% accuracy, and the problem is with the lesions that are less than 2 centimeters in diameter. As I mentioned before, when they're of that size, we have a 50-50 chance of being right, because it's very common in patients with cirrhosis to get shunts, pseudo-lesions, due to the changes in the microcirculation of the liver that can show as these hypervascular lesions less than 2 centimeters in size. But on sequential imaging, they will either regress or disappear. Hepatoma will grow. Dysplastic nodules, if they happen to be hypervascular, will remain stable in size. Okay, so just to summarize, hypervascular liver lesions, they're incidental finding and they're hypervascular, most likely to be hemangioma, FNH adenoma. These are incidental findings. Other entities we'll touch on are hyperplastic regenerative nodules in chronic Budd-Chiari. It's a very specific thing in a specific disease entity. Malignancy, you're thinking of HCC and hypervascular metastases. Okay, this is an example of Budd-Chiari. Talked about hepatoma and cirrhosis. If you see cirrhosis, you see a hypervascular lesion, particularly if it's touching 2 centimeters in size, you're thinking of hepatoma. If your cirrhosis is due to Budd-Chiari, you tend to get hypervascular, the patient tends to get hypervascular regenerative nodules. They're different from the regular regenerative nodules. They tend to be hypervascular, so you shouldn't confuse them with multifocal HCC. Only in this situation. I have seen in autoimmune hepatitis, but this is the most well-recognized. And that's the thing, when you get some brownie points, you say, well, it's a hypervascular lesion, you've got cirrhosis, you're thinking of hepatoma. But if this was due to Budd-Chiari, then, it could be regenerative nodules, and you can follow them up, look for stability. Some people do biopsies in this situation, but those patients should not be written off. So cholangiocarcinoma, let's move on to that. This is the second commonest liver primary. I think this is one of the hardest tumors to actually detect, because of it doesn't enhance well, it can be very infiltrating. It's a desmoplastic tumor, so it tends to cause scarring. It rises from the biliary epithelial cells. It's associated with duct dilatation. There are many etiological factors that are in your syllabus. I won't go over them. Primary sclerosing cholangitis and Crowley's disease being examples. So here you've got an ill-defined tumor. Characteristic thing about cholangiocarcinoma, because it tends to be it's called scarring, it shows enhancement on delayed phase imaging. So if you see an infiltrating tumor, it can be in the hilum or it can be peripheral, delayed phase imaging, dilated ducts, you're thinking of a cholangiocarcinoma. Another feature is capsular retraction of the liver, another feature of cholangiocarcinoma. Now here's an example of a cholangio that's involving the common bile duct. This was missed first pass. You have to look carefully at the wall of the bile duct. The wall of the bile duct should be kind of, almost imperceptible. It's just millimeter thick or so. Look how thick this is. This is on a CT cholangiogram. Actually, I'll show you in a moment. Here you can see contrast filling that duct. So this was a central cholangio. Now the ones that occur centrally, whether they're coming from the common hepatic duct or whether they're coming from the parenchyma of the liver, if that's the hilum of the liver, they tend to be referred to as Klatskin tumors. And then those beyond the second order ducts are the peripheral tumors. Here's a MIP from an MRCP image, and in these images what you might see on the MRCP image is a signal void where the tumor is causing a stricture of the bile ducts. So irregular margins, bile duct dilatation, high signal on T2. I think MRI is actually very helpful for cholangios because you get better contrast, so it can make it slightly easier to see the tumor. This is a T2-weighted image, fat suppressed. You see this subtle, ill-defined mass in the center of the lesion. The GAD images I find most helpful for looking for duct dilatation. So again, you can see there's dilated ducts and this central ill-defined lesion. On the delayed images, you can see subtle enhancement of the tumor. So characteristic cholangio. Now, diffuse liver diseases, I'm going to zip through this. Cirrhosis. Cirrhosis is a chronic response to liver injury. What happens, the liver gets injured, there's an inflammatory response, The injured liver then regenerates. Eventually, there's fibrosis. Fibrous tissue is laid down, particularly if the injury continues. The fibrosis causes an alteration in the microcirculation of the liver and eventually leads to portal hypertension. Many etiological factors, but alcohol and viral hepatitis is the commonest in the US. We all know that cirrhosis can cause changes in the morphology of the liver, and it's called surface nodularity of the liver. And the nodularity of the liver is attributed to the presence of these regenerative nodules that occur. Other features that we all, I hope, are familiar with is ascites, splenomegaly, evidence of collaterals, and you can get bowel wall thickening. Can affect any part of the bowel, can affect the whole bowel, but most commonly it affects the hepatic flexure. So earlier on, early cirrhosis may be inapparent on CT and MRI. It's very early. Some of the early signs that you can see are diffuse enlargement of the liver, heterogeneity in the blood flow, in the perfusion of the liver as you start getting some alteration in the microcirculation. You can see enlargement of the periportal and perihilar space as the liver starts to sort of scar a bit, and you get increased fat deposition in the porta hepatis. Some of the earliest segments to undergo retraction and scarring are the anterior segments of the right lobe and medial segments of the left lobe. As these shrink up, you can imagine the gallbladder will rise up, another feature of cirrhosis. So what are regenerating nodules? These nodules are thought to be responsible for the surface nodularity of the liver, and they are a response to chronic liver hepatocyte injury. They, on T1 and T2, will have a similar background appearance to the liver generally because they are regenerating liver cells. However, they can contain iron and appear very dark, or they may contain copper that can make them appear bright, but generally it's iron. So these are these so-called siderotic nodules. Now, as far as MRI and CT goes, MRI is much, much more sensitive for detection of regenerative nodules because of the iron content. And here's an example. These two images were taken 1 week apart, same patient, same liver. CT looks fine. No obvious nodularity. MRI is filled with siderotic nodules. This is because the MRI picks up that iron. Obviously, advanced cirrhosis is easy to characterize. As you get atrophy of certain segments, you can get hypertrophy of the lateral segment or of the caudate lobe in compensated liver disease. Some people advocate measurements of all these segments. I'm really not into that. You should be able to tell just by eyeballing what's going on. Dysplastic nodules. People stress about what dysplastic nodules are. These were first described in the 1980s at pathology in Japan. These nodules were noticed that looked different from regenerating nodules. They were different in color and the size, and they were given a whole slew of different names in the past that was very, very confusing. Forget all of those, we call them dysplastic nodules. Now, what's the difference between a dysplastic and a regenerative nodule? The difference is that dysplastic nodules will have a certain amount of cellular atypia. They can be low grade, a little bit of atypia, or high grade, a lot of atypia. That is what a dysplastic nodule is. Now, if you look at the literature, these are supposed to be pretty common. They're up to 25% of cirrhotic liver specimens, usually less than 10 per liver. When we look at imaging, we're nowhere near that mark because quite often we don't bother looking at them and their appearance can be pretty variable. Why are they important? Because they have cellular atypia, obviously they can dedifferentiate down to hepatocellular carcinoma. It used to be thought that there was a straight route from normal liver, regenerative nodule, dysplastic nodule to HCC. Now we know you can get HCC in liver without having cirrhosis present. And we also know that, but on the other hand, we also know that microscopic foci of tumor of HCC can occur within dysplastic nodules. So it's probably not one contiguous process, but two different signs of liver injury that's going on. When you see dysplastic nodules, there are two things to think. One is that you need to look carefully at that lesion on follow-up. You have to watch it on follow-up because it can change into hepatoma, but it also indicates that that liver on the whole is at risk of developing hepatoma. What do they look like? Oh, well, first, longitudinal studies, natural history. As I mentioned before, you follow these lesions up. If you look at longitudinal studies, dysplastic nodules remain dysplastic nodules unless they increase in size. Then they have become a HCC. That's how you tell. Okay? And another important thing, probably the most important thing about dysplastic nodules is that they should be dark on T2. Anything that's bright on T2, you're going to call that a hepatoma, right? A focal rounded lesion is going to be a hepatoma. You don't call it a dysplastic nodule. But if you see a focal lesion, whether it's hypervascular, and about 12% of them are hypervascular, or it's not, it's a focal lesion and it's sort of under 2 centimeters in size, you follow it up. If it grows, it's a hepatoma. So here's the characteristic appearance that people talk about. The most important one is that it should be dark on T2. Classically, it will be bright on T1. Classically. Not always, classically. Dark on T2, and classically, this is not enhancement, this is still, it was bright on T1 before, bright and afterwards, it doesn't enhance. But about 12% or so can show arterial phase enhancement, and they should be less than 2 centimeters in size, of the order of 1.5 centimeters in size. Okay, let's talk a bit about fibrosis. Fibrosis is obviously an important feature of cirrhosis. It can be diffuse or focal. It's dark on T1 and it's bright on T2. Diffuse fibrosis is seen as these hyperintense bands of tissue or lines sort of making their way through the liver parenchyma, as you're seeing here on this T2 weighted image. It can show enhancement on delayed phase imaging because it's fibrous tissue, and fibrous tissue does enhance on delays. You can get focal confluent fibrosis. When this occurs, it's classically seen in the anterior segment of the right lobe or medial segments of the left lobe of the liver, and it classically should be triangular and associated with capsular retraction. If it doesn't show all those classic features and it's a focal area blob of bright T2, obviously you're going to worry about hepatoma. The patient may undergo an arteriogram, which is what we do in common practice to confirm that there's a hypervascular region, or some places may biopsy. We don't generally tend to biopsy. This obviously is just a table of all the collaterals that's in your syllabus. I'm not going to go over that. Let's talk a little bit about fat infiltration of the liver. This can be diffuse. We talked about focal earlier. There are many different causes. Obesity is a common cause now that people talk about. Total parenteral nutrition, alcohol, pregnancy. Even when it's diffuse, the distribution can be quite heterogeneous. On CT, it's seen as areas of low attenuation that are geographic. Very common in obese. In ultrasound, you can detect moderate steatosis, where you get increased echogenicity of the liver, loss of reflectivity of the diaphragm and kidney. On CT, obviously, you're going to measure the Hounsfield difference between the liver and the spleen. If the difference is more than 10 and the liver is darker, then that is fatty liver. On MRI, you do in and out of phase imaging. You look for signal phase on signal loss on out of phase. On contrast enhanced images, some people have suggested you can measure the liver and spleen differences. Don't bother with that. Completely unreliable. Depends on your circulation. Lots of other factors involved. Not reliable. You can look at the paraspinal muscle in the liver. The liver should always enhance more than the muscle. If it doesn't, you're thinking of fat. Another clue is patchy areas of enhancement, focal fatty sparing. But a non-enhanced is more reliable. Okay, let's talk about hemochromatosis. This is an autosomal recessive condition, which is associated with an abnormal absorption of iron from the GI tract, so much so that it cannot be stored by the normal reticular endothelial system. Therefore, it's deposited in places where it shouldn't be, such as the heart, the pancreas, and within hepatocytes, not just Kupffer cells. So you get darkening of the liver. The T2 susceptibility effect of iron makes it look dark on T2 weighted sequences and on gradient echo weighted sequences. So a very dark looking liver, darker than paraspinal muscle is what you normally use for as your index. Big heart, iron deposition, dark looking pancreas, all features of primary hemochromatosis. Diagnosis is usually made biochemically and on chromosome analysis, and ultimately confirmed with liver biopsy. Now on CT, what will hemochromatosis do? Iron deposition causes increased attenuation of the liver, usually between 70 and 130 Hounsfield units. Studies have shown that imaging is pretty good with biopsy findings. People have looked at the relative signal of liver iron to liver signal relative to paraspinal muscle and shown that it's very representative of liver biopsy. Obviously, untreated, you're going to get cirrhosis, and there's an increased risk of hepatoma. Here's just an example of a patient who had a hyperattenuating lesion, presented over time, has a pacemaker. This is due to amiodarone. So on CT, you can see liver iron due to increased attenuation, but there are other causes of increased liver attenuation that you should have a short list of in your head. Hemosiderosis is slightly different. It's usually a result of a erythropoiesis or multiple transfusions. The excessive iron is accumulated within the reticuloendothelial system. So in other words, in the Kupffer cells of the liver, in the spleen, and in the bone marrow. These organs may be enlarged and will appear dark on T2 and gradient echo-weighted sequences. Hepatic vein thrombosis, Budd-Chiari, due to reduction in size or occlusion of the hepatic veins, presents acutely with hepatomegaly, ascites, and jaundice. Many different causes. Idiopathic is the most common. They're different categorized according to the level of the obstruction. I'm not going to go over all of these because we're short on time. And the important thing to remember is that the liver becomes very congested, so what you see is enhancement centrally and hyperperfusion peripherally on the venous phase, which can be reversed on delays. You will see ascites present. Eventually what will happen is that the liver will undergo atrophy. Now, just because it's hepatic vein thrombosis doesn't mean you will necessarily see thrombi within the hepatic veins. You may actually see them, but they will appear small. Frequently, this can be associated with portal vein thrombosis. There are many different causes of this, including inflammation and tumor. Here's an example: portal vein thrombosis, lack of enhancement of the portal vein. Eventually, this will atrophy and you'll get collaterals. Okay, one final thing to measure about portal vein thrombosis is that you can get these THADs, these triangular areas of hyperperfusion, which are due to when you get a reduction in portal venous flow, you get an increase in arterial flow in association with this. And so usually those are due to idiopathic causes, but can be due to tumor, so look carefully at the apex. Just to show you what nutmeg liver looks like. I'm slipping through this because we're kind of running behind now. And this is the final thing, is hepatic infarction. Hepatic infarction is uncommon, obviously, because it's due to, you have a dual blood supply. Usually when you get it, it's due to some iatrogenic cause, surgery, transplant, laparoscopic cholecystectomy. What you're going to see are geographical areas of low attenuation. Due to the acute infarct, you may get ascites present. Eventually, what will happen is those areas will undergo atrophy. Bile ducts are very sensitive to ischemia, so within these you may get necrosis, but you can also get bile lakes forming, cystic areas, pools, funny-shaped areas of low attenuation. Okay, and eventually that segment will undergo atrophy. An important clue to infarction is that it changes in shape and size with time. So just to summarize, multi-phase CT is the preferred modality for evaluating the liver, and MRI really is your backup modality for evaluating indeterminate liver lesions, and it is more sensitive for detection of fat and cirrhosis. Thank you, and here are your case answers.